Welcome everyone to our BJ podcast for the month of August. I'm Andrew Duckworth, and a warm welcome back to you all from your team here at the Bone and Joint Journal. As always, we'd like to thank you all for your continued comments and support, as well as a big gratitude to our many authors and colleagues who take part in the series, highlighting some of the great work published by our authors each month. So today, for our monthly podcast, I have the pleasure of being joined by the lead author on a paper published in the August edition of the BJJ entitled "An Analysis of the Effect of the COVID-19-induced Joint Replacement Deficit in England, Wales, and Northern Ireland suggests recovery will be protracted." An analysis of the National Joint Registry. So I'm very pleased to be joined by Mr. Jonathan French, who is a clinical research fellow at the University of Bristol. Thanks very much for joining us, John. It's really good to have you with us.
Thank you very much for having me.
So, John, the primary aim of this study was to quantify the backlog, analyse national trends, and predict the time to recovery of joint replacement in light of the COVID-19 pandemic and how it disrupted the provision of arthroplasty services in England, Wales, and Northern Ireland. So, John, maybe as a background to the study for our listeners, can you give us some insights into the state of these services prior to the pandemic?
Yeah, sure. So I confess I did a bit of a Google as to what was happening in 2019 before this podcast. And Theresa May was PM, was succeeded by Boris Johnson, and Trump was PM president of the US.
Yeah.
So in terms of the NHS, there were 4 million patients on the waiting list back then, and that had increased from 2 million back in 2010. And even in 2019, no specialties were meeting the waiting list target of 92%. Seen within 18 weeks. And if you look specifically at hip and knee replacements in England, more than a quarter of patients were waiting more than 18 weeks for surgery, even back then.
Yeah, and that's interesting, John, isn't it? Because I think that puts into context the paper and the data you're about to discuss with us. Because even back then, it wasn't quite right either, was it? And there was still a big problem. Yeah. And so, what about data we have already on how maybe provision was affected and changed? I mean, maybe even recovered since the pandemic. Is there anything out there already?
Yeah, so our unit published an earlier study along similar lines to this one, where they looked at the numbers just in 2019 and 2020. And that was joint replacements done in England, Wales, Northern Ireland, very similar methods. And what they found was that in 2020, we lost around half a year's worth of procedures.
Yeah.
And the impact was seen more in Wales and Northern Ireland, about 20% more.
Yeah. That's very interesting. And that moves us very nicely on to your sort of work that you've done here. So this was a prospective observational registry-based study. It involved analysis of the NJR for all hip, knee, shoulder, elbow, and ankle replacements in England, Wales, and Northern Ireland between January 2019 and December 2022 inclusive, which included just under 730,000 operations. So, John, for our few listeners that maybe are not familiar with the NGR, can you just give us some general details of this data resource, and particularly in terms of the quality of data capture, the type of information that you looked at?
Yeah, sure. So the NJR, it's the largest registry in the world, and it captures primary and revision procedures in both the public and the private sector in England, Wales, Northern Ireland, the Isle of Man, and Guernsey. It's mandatory for submission, and the data capture is around 97% for primary hip and knee procedures. So it's a really good quality source of data.
Absolutely. Yeah, and it's like I say, that amount of data capture, particularly for hip and knee replacement, is very impressive. And so you had that data, obviously you collected it for that period of time. And so what analyses did you carry out? And I suppose quite important to that, what assumptions were made as part of this?
So we looked at the period of 2019. So that was taken as the baseline before COVID hit. Then we looked at 2020, 2021, and 2022. So lockdown started in March 2020, and restrictions ended in around July 2021. So that gave us around 18 months of data after the end of the pandemic. And what we did is we took 2019 as a baseline, and we made the assumption that the provision of joint replacements wouldn't change from that. And each year we then calculated what we termed the deficit, which is the amount of joint replacements that weren't done had we seen a continuation of 2019 volumes. And then we broke the analysis down by the type of joint replacement, and then also we looked at each home nation specifically. And the last thing we did is we looked at the provision in the NHS and compared that to the independent sector.
Yeah, and just to say, John, the collection for the independent sector is quite complete as well. That's correct.
Yes. So the 97% includes the independent sector as well.
Yeah,
and that's a real strength of the NJR. And I should probably mention that if you look at the trends before 2019, in the decade or so before that, we were looking at an increase in joint replacements of around 5% a year. And the projections are that that was going to continue to increase with our aging population. So probably these estimates are underestimates, if anything.
Absolutely. Yeah, no, I think that's a very important point, isn't it? So, John, if we describe obviously how it was done. So, in terms of the results of the study, firstly, what did you find in terms of the current deficit and how that had changed since the pandemic?
So, in total, we've lost around 160,000 procedures, and that equates to just under 3/4 of a year of normal operating.
Mm-hmm.
In terms of the deficit per year, it was 47% down in 2020,
Mm-hmm.
19% in 2021, and 5% in 2022.
Yeah.
So I suppose the good news is that deficit is narrowing, but the bad news is that even in 2022, we hadn't done the same amount of operations as we were doing in 2019. So we're still
Absolutely.
actually falling behind.
Absolutely. So it's still yet to recover those numbers. Absolutely. And
Yeah.
how did that vary in terms of type of joint replacement being formed?
Quite a lot, actually. So hips and elbows were relatively spared. So they lost around 6 months of procedures, whereas the worst hit was, in terms of absolute numbers, was knees. So
Mm.
we lost around 95,000 knee replacements. So that's 10 months of operating. And in terms of relative numbers, ankles are about 11 months behind, but the numbers are quite small for ankles comparatively.
Absolutely. Was there any sort of, just before we move on, any thought about why hip was more protected than knee at all? Or
Yeah, I mean, we thought about it. We don't have any definite answers, but if you look at the spared procedures relatively, elbows definitely are a large proportion are done for trauma.
yeah.
And so that was maintained in the pandemic above the elective indication. So that could explain elbows.
Mm.
If you look at hip replacements, it's such a small minority that are done for trauma.
Mm.
Actually, that doesn't bridge the gap between what we saw between hip replacements and knee replacements.
No.
So it must be to do with prioritization or the way that services are structured. If you look back to the 2019 data, already patients were waiting longer for knee replacements and hip replacements back then. So
Yeah.
probably whatever's changed is kind of exacerbated the forces already at play.
I see what you mean. Absolutely. And what was the variation seen between sort of the three home nations that you looked at?
So again, there's wide variation there, where we saw Wales and Northern Ireland hit considerably harder than England.
Mm.
So in Wales, about 16 months of operating has been lost, and in Northern Ireland, 15 months. So they've lost more than a year, and that's compared to 8 months in England,
Yeah.
which is still bad, but relatively less. And then if you look at the way that the deficit is recovering, that's slower as well. So in 22, England was 5% down, but Wales was still 25% down.
Yeah.
So they've lost a lot, and unfortunately, they're continuing to lose more.
Yeah, absolutely. And I think that's quite interesting, isn't it, in terms of a provision of services in particular, but also in provision of services is you looked at between the variation between the public and independent sectors, and that was quite interesting, wasn't it?
Yeah, that was very interesting and unexpected, I think. So what we saw is in 2020, both sides were hit hard, and we saw a big reduction in numbers, as you'd expect. Then in 2021 and 2022, what we've seen is the independent sector has really bounced back and expanded beyond 2019. So
Yeah.
in 2022, independent sector operating was up 127%, whereas in the NHS, it's still down at 70 something percent.
Yeah.
So what's that meant is that we've seen an inversion in just a few years, where independent sector provision was around 40% in 2019, and
Mm.
it's gone up to 53% in 2022. So most joint replacements are now done in the private sector.
That's an incredible figure, isn't it? And I know the pandemic happened as the main driver of this, but that change of where you say that joint replacement now provision is now majority done in the private sector is quite a really stark finding, I think. And in terms of all that, so you drag all that together, you do a very nice summary in terms of what these numbers mean in terms of what needs to be done to address these deficits. Can you just go through that for our listeners?
Yeah, so we did some calculations based on the deficit incurred, and then if we were to hypothetically be able to expand services right now, how many years would it take until we were back to where we were in 2019?
Mm.
So if we could immediately expand today by 10% of the operating we're doing, it would take us until 2031 to eliminate the deficit. So to get back to 2019, when there were still 4 million patients on the waiting list.
Yeah.
And as you imagine, if you break it down by Wales and Northern Ireland, look at them specifically, they would require a larger expansion. So it would be 15% now to address their deficits within a decade.
Just to be clear, that's an immediate expansion on what the 2019 levels were or what the current levels were?
Sorry, 2019 levels. So we're still 5% behind, and we were in 2022.
In 2022, exactly. So it's an expansion on top of that rate. Absolutely, yeah,
exactly.
And I think again, I found that very, very interesting actually. And I think so. Like, if we go on to sort of what all this means, I think the strengths and importance of this data, I think, are just without doubt clear. It's a big data study, including analysis with national coverage of both. It has independent and NHS providers of arthroplasty, mandatory data capture, as you said, to the NGR, and primary case ascertainment in excess of 90% for hip and knee arthroplasties in particular. And I think the findings are very sobering. And highlighting the arthroplasty deficit following the pandemic is now equivalent to over 2/3 of a year of normal operating activity, continues to increase. And even with those expansions in capacity from the 2019 level that you describe, it will still take years to rectify. I mean, it's quite profound, that, I think. And how have you and your team sort of interpreted these findings? And I suppose, was it to the degree you expected and the findings you expected?
So I think personally, from me and what you see in your clinical practice, I think we all knew that COVID has had a profound effect and patients are waiting longer. But I think the overall findings are probably slightly worse than we expected, in that I think we had expected that by 2022, we would at least be doing as much as we were in 2019. And the fact we're not and still falling behind is probably slightly worse.
Yeah.
On top of that, I think the inequalities that are emerging between the nations, there's been some news coverage, but again, they're slightly worse than we expected.
Yeah, I think that's very true. And I think you use that word inequality. I think it is between the nations, as you see. And I suppose the other inequality is from the public to the private sector, isn't it? And in fact, that actually, if you can afford to pay, then actually your access it would seem is actually potentially easier and quicker, as we would expect. But to such a degree, I was quite surprised by that finding, I have to say.
What I should mention is that although it's the providers have changed,
of course, yes,
it's still majority NHS funded procedures.
I'm with you, absolutely.
And we did look at the funding, and that has seen a change, but it's not as dramatic. So we're seeing a steady increase in the amount of independently funded procedures.
Yeah.
But the big explosion in the independent sector is NHS funded, so choose and book.
And that's a very important point, isn't it? And I caveat what I said, because obviously there is something there, but it's amazing that returning capacity there, as you've highlighted. And in terms of how that fits with, you talk about data from Scotland and from the US and from Europe. It's not that dissimilar, really, is it? In many ways.
Yeah. So there are similarities and differences. So Scotland they're separate from the NJR. They've got the Scottish Arthroplasty Project, and they've published their results up to the end of 23 now. So that's actually a year more than we've got. And the picture is very similar, as you say, where you can see in 2022 it was still far below 2019, and even in 2023 Scotland hasn't recovered to 2019. And there was a really good piece in Bone and Joint Research about expansion in Scotland, and a 20% expansion would still see patients waiting for 1 to 2 years for surgery.
Absolutely.
So quite bleak there. And then just very briefly, internationally, if you look at the US and Australian data from 2020, they saw big decreases, but actually their recovery has been a lot quicker. And their registries have even stopped reporting COVID, because presumably it's not an issue.
Absolutely.
Whereas Canada has been hit hard. By the end of 21, they were still lagging behind, and they actually collect length of stay data, and they've seen 100-fold increase in day case hip and knee replacement since the pandemic. But even with that, they're still far down in terms of volumes.
That's really interesting to put all those different areas into context, and different healthcare systems to a degree as well. I think that's really interesting. And in light of all that as well, John, I think we've obviously discussed the strengths of the study, which are completely clear. But are there any sort of limitations or caveats to the data you would want to put out there?
Yeah, well, so I think the main limitation is that we've been talking about procedures lost, but actually these are just projections.
Yeah.
And we've made big assumptions that 2019 volumes would carry on. And we actually haven't looked at demand. We're looking at purely provision, so how much we're doing.
Yeah.
And as we've mentioned, probably there are factors which might make estimates conservative, such as the fact that the provision was projected to increase.
Yeah.
On top of that, when we see patients with long waits, they're often anaesthetically more complicated, more frail, and surgically more complicated.
Mm.
So you can get a knock-on effect and a vicious cycle where the cases are taking longer, and that's exacerbating the issue.
Yeah, definitely. I mean, that's certainly something I hear from my orthoplastic colleagues here in Edinburgh is actually that deconditioning and the length of time that people are having to wait, they are frailer patients and more
Mm,
complex procedures and
mm,
worse arthritis, all those sort of things. So
mm.
it's difficult, isn't it? And so maybe to finish up, John, and in reality, we talk about those projections that you talk about, or what the expansion would need to be, should I say? Is it felt that this can really be achieved, given the current strains and pressures on the healthcare service that we have at the moment and restricted resources? Is it possible? What are there options out there that can maybe make it easier or better or to achieve?
Yeah, well, I think these are big questions and difficult to answer, especially for us as surgeons. And I think maybe that's why I started talking about who was PM at the start, because I think a lot of the answers will come from policy and politics. So what we did in the paper is we tried to put it all into context. So we talk about a 10% expansion. We'll see us recovered by 2031, and 10% sounds doable. But if you think about it in terms of that's like every hospital in the country doing 5 weeks of extra operating
Yeah,
a year. So that's a lot of weekends.
absolutely.
Or it's equivalent to building about 20 high volume surgical hubs, which do 500 hips and 500 knees a year.
Yeah,
Again, it's a pretty big infrastructure change. So
yeah,
whether it's achievable, I'm not sure.
yeah,
In the meantime, there are plans to continue to expand into the private sector. And we've talked about inequalities. And I think the other thing is geographical, where independent hospitals are built where the money is. And so
absolutely.
affluent patients will have the option of choose and book by virtue of living in the area.
Yeah,
So that could still exacerbate the inequalities there. And I guess secondly is an issue, I'm a registrar, so an issue close to my heart, which is training. And the fact that we now have the majority of joint replacements, well, not easily accessible to trainees is a big barrier to training. And potentially, I wonder whether we'll see changes there. And then on top of that, knock-on effect is NHS patients are more frail and complex surgically, anaesthetically, all of which increases pressure on training.
absolutely. No, well said, John. I think that's very true, and I think it sort of highlights all those potential issues. But we can but try and try for our patients. And I'm well, John. I'm afraid that's all we have time. But thank you so much for taking time to join me and highlighting, I think, a really important paper. And I think not only obviously for our specialty and for those who make policy, but I think most importantly for our patients, because I think it really advocates for our patients and what they're having to go through in terms of the weights that they're having to go through and the demand that is out there for our services. So thanks so much, John, for joining us. It was great.
Oh, well, thank you very much for having me.
And to our listeners, we do hope you've enjoyed joining us, and we do encourage you all to share your thoughts and comments on the various platforms and feel free to post about anything we've discussed here today. And as always, thanks for joining us. Take care, everyone.